I think that when you sign on to be a veterinarian, I think you're signing on for a lifelong endeavor. And it's easy to get complacent, and complacency is the enemy. Read, read, read. So I think that those things are, critical to staying engaged and keeping it current and keeping you excited about what you're doing.
Hello, and welcome to the Veterinary Cancer Pioneers Podcast, the show where we delve into groundbreaking work of veterinary professionals dedicated to advancing the field of veterinary oncology. I'm your host, Dr. Rachel Venable, and I'm thrilled to embark on this journey with you. Today's episode is brought to you by ImproMed, pioneers in AI-driven precision medicine for veterinary oncology. Their personalized prediction profile helps you make confident treatment decisions for your canine lymphoma and leukemia patients by predicting how your patient could respond to multiple chemotherapy protocol options. Learn more at impromedicine.com. That is IMPRImedicine.com. Hello, and welcome to the Veterinary Cancer Pioneers Podcast. Today, I'm so excited. I have Dr. David Ruslander, and we're really going to dive in and learn more about the different aspects of his career. He is both a medical and radiation veterinary oncologist, and he's also practiced in private practice, academia, corporations. We're really just going to get to dive in and see how things have changed and just learn more about what he's seen throughout his career. And Dr. Ruslander, he integrates surgery, chemo, radiation, and immunotherapy to improve outcomes and quality of life for pets with cancer. He earned his veterinary degree from Cornell, completed a medical oncology residency at Tufts, and received radiation training at the University of Zurich. And he's also the past president of the Veterinary Cancer Society. Dr. Ruslander, thank you so much for being on our show today.
Thank you very much. I'm very excited to have this talk.
Oh, thank you. And, I always like to start with what got you into either veterinary medicine or certainly oncology. A lot of people, when I was a kid, I didn't even know there were veterinary oncologists. So what got you down this path?
Yeah, I kind of got involved in it early in my career. Initially, I started out in equine medicine, and then I transitioned to small animal medicine. And during my education, oncology was kind of the forgotten specialty. And we had a lot of patients that were being treated for kidney disease and heart disease. And then when they got the diagnosis of cancer, there were a lot of options at the time. And it seemed to me that there was, opportunity not only for myself, but also opportunities for clients that didn't want to give up when patient was diagnosed with cancer.
It is hard. I think for a long time, and even now, a lot of people don't realize what options are out there or how animals tolerate chemo. It's also interesting you said equine. Dr. Vale was the same. He was thinking equine actually initially too. So it is kind of funny how a lot of people don't go in thinking oncology. I mean, I didn't. I didn't even know it existed when I got into vet school either. So it is really interesting seeing that. And the other thing I wanted to know more about is you went to the University of Zurich. That sounds really fun to me. How did you end up in Zurich?
Well, it was very interesting. So I was a clinical instructor at NC State, a non-tenure track position. There was a woman, Dr. Kaiserholz, who had trained at Colorado State University, and she was building the program in Europe, and they didn't have many oncologists in Europe at the time. So she was looking for someone to balance the radiation oncology that she did and with the medical oncology. And at the time, my wife, we talked about it, and it was no tenure, no mortgage, no kids. And so it was a no-brainer to go there. And as I look back 25 years ago, it seems like a dream and it was an amazing experience.
I can only imagine just, I really haven't been to Zurich. It's on my list, but it seems like a really pretty place. And that was probably exciting to be one of the first people really building up a program. What was that experience like?
Oh, it was amazing because, at the time, Europe did not have many oncologists, and it was a little bit like it was in the States, 10 years before. And so a lot of people had a lot of misconceptions about treating patients with cancer. And so it was an amazing experience to kind of educate not only the clients, but also the veterinarians at the time.
Yes, like we were saying, it is interesting. A lot of people don't understand, even today, how oncology in animals is very different. And sometimes even the veterinary community, I think with anything, you have a couple cases that, just the outcome's rough. Maybe it's a bad disease. And so then you just kind of get that stuck in your mind and don't think about the other statistics and things. It's something we had talked about at a conference recently, was just the backstory of a lot of people, why they come and see the oncologist. And I think a lot of times people also don't understand that. Would you mind sharing maybe a story or two?
Absolutely. You don't know what you don't know. And whenever I talk with an owner, the first thing I always ask is, where did you get the name of the patient, especially if they're unusual names, and just kind of get a sense of, where they're coming from, and, ask the questions that, sometimes are difficult questions to ask, but a lot of times people will volunteer the information. And, two that come to mind were a patient of a dog that had a brain tumor, and the owner spoke to me, candidly, and he said that, he had two little kids, and his wife was diagnosed with cancer, and she chose not to go through the chemotherapy and the radiation therapy. And he told me that he wanted to teach his kids not to give up when things get tough. And it was like um, a very touching conversation we had. And then another patient that I just saw recently with a dog with a mast cell tumor that had very advanced disease, very difficult tumor to treat. And we ended up um, losing the patient early on in treatment. And when things were going downhill and they still wanted to treat, I, spoke with the owner, and they volunteered the information that, this dog belonged to their daughter. It was a young couple. So I think that the daughter was very young when she died. And they said that, this is the last thing to remember her by. And so, you don't know what you don't know. And I think that it really is testimony to making sure you get, as you say, the backstory and understand kind of where the people are coming from and what their motivations are.
Oh yeah, I mean those are just heartbreaking. And it makes sense why they wanna see an oncologist, why they wanna do everything they can, and I think it's important also for just the veterinary community as a whole to know that and to remember, referral. And even in cases, like you said, that one was a really bad mast cell tumor, like, they may be thinking like, "Hey, there's not much that we can do here," but sometimes just for those people knowing that they crossed every bridge, right? That they did everything they could. Like, I can't imagine, I mean, if that pet was all I had a connection to someone I love so much, like a daughter or son or, any kind of family member, I would wanna do everything, it's just hard to let go. So, yeah, that's tough. And, you said that you will ask questions and sometimes they're hard questions. How do you get people to kinda open up about maybe why, other than just their pet, why they're coming? Do you have any tips on that, or is it just how the conversation flows?
Well, the key is, to let them talk. I think that a lot of times with conversations, they tend to be one-way conversations with the owners, and we talk and they listen. And I think that, now we're seeing courses and education in client communication. And I think that no one like uncomfortable pauses in conversations, but I think that that's where a lot of the information comes from if you just take a step back, let them collect their thoughts, and then they will open up.
It's true. I 100% agree. I think there's just so much power in that pause. When I used to work with training vet students, I remember we would talk about, after the consult, we would talk later and they would always say it was so hard, like it was awkward, when no one's talking, like when the pet owner's crying, but then they saw how powerful it was to just give them a minute. So yeah, I 100% agree. And you are in academia and just private practice and corporate, how would you compare all those different settings?
There are variations and a common theme. I think I talk about academia. You have a lot of hats that you have to wear, 50% teaching, 50% clinics, 50% clinics. And so you're wearing a lot of hats. I think when you go to private practice, it shifts a lot, obviously, towards the clinics. But you also have a lot of opportunities to get involved in research, either in, multi-institutional studies or submitting cases for retrospective studies. It's all what you want to do with your time. And it really has been very rewarding for me to be involved with research, at other vet schools that are doing the primary research.
Yeah, I like to get involved in research too, and it's sometimes I find it can be a bit challenging in private practice, just trying to corner out the time and things. How would you recommend for people that are in private practice but they still want to stay involved at some level of research? Like, is there anyone you recommend maybe reaching out to, or just how can they kind of get into that niche?
Well, I think that I always say start with your mentors where you've done your residency programs, and most people stay in contact with their mentors and find out what they're doing, find out where the research is being done. I think that between VCS, ACVIM, ACVR, there are a lot of collaborative projects that are being done. And so I encourage people to get involved in these organizations, if not on committees, but getting involved in a lot of these collaborative groups that are doing research that can get the job done and provide the infrastructure to do the research.
Right, and I think it is so important to really work with private practice and academia because I think private practice, you just see such a higher volume. You're more apt to be able to enroll and see those cases versus academia. They may have the setup for really the sample collection and all the backside of things, but they don't really just have the caseload so much, especially not as much anymore as more and more specialty hospitals pop up. And what would you say, just kind of even comparing academia and private practice? What were some of your favorite highlights and maybe some of the things that are challenging between those two?
Well, I think in academia, you're involved with a lot of cutting edge research, cutting edge technologies. I think, historically, when I came out of my residency, there were very few private practice jobs. And so if you wanted to be involved in any kind of research, and frankly, even having a job, there were not a lot of jobs in private practice when I came out. Now, it's kind of flipped where there's a lot of jobs in private practice. And so I think that, it really is, again, variations on a common theme. I think that there is a lot of work in academia with clinics. As you say, the caseload may not be as great, but you're also doing the research, you're teaching the students, you're teaching the residents. And I think that that consumes a lot of time. In private practice, you can have residents, you can have interns. We have externs, interns. We have residents that spend time in our clinic. But it is kind of definitely front loaded with the clinical work.
Yeah, well, and I think that's great that you're also still doing the teaching, having them rotate through with different things. Cause I do think it's important for them to see like how, a busy private practice and what that looks like. Now, when you treat, so you're medical and radiation oncology, so you're two specialists in one. How do you think that really changes how you approach cases? Or is there anything you would recommend for other medical or radiation oncologists about maybe how we could work together better?
Well, I think that collaboration is key. I think that when I go into a room, if the patient is coming in for treatment, I go in with my, oncologist hat, not with my radiation oncologist hat. So I will look at the way I phrase it, what makes sense for the disease, what makes sense for the patient, and what makes sense for the caretakers. And so I don't come in saying, okay, you're here for radiation therapy, you're getting radiation therapy. And I think that getting everybody's opinion before you give chemo, before you give surgery, do recommend surgery, radiation therapy, is figuring out what's best. And then that is, communicating with the specialist. And as you say, I have a background in both, but I'm doing more radiation therapy. And so I, usually will speak to all of our medical oncologists that are in the hospital before I make any kind of final decisions. We're very fortunate in our group, with multiple surgeons, multiple medical oncologists. We have surgical oncology rounds once a week for difficult cases that may benefit from the insight of not one surgeon, but all the surgeons and all the medical oncologists, and get everybody's opinion, because everybody's trained differently. And, their experience is what matters. And I think that that makes a difference of having a good outcome and or not a good outcome.
And it's interesting, there's some things that we have a lot of research and data because I feel like oncology, everybody wants to know numbers. But then there's other things where we really don't. And I do think you get a lot of difference of opinions, sort of rightfully, because we don't have a lot of data on those. So that is really nice that you guys are able to do rounds and have all the different specialists there. What would you say it sounds like client communication is certainly a big part of your practice, which I agree. I actually really like client communication. I think it can kind of make or break you. We've all met or even in our own experiences with doctors, where if they just have a terrible bedside manner, like it's hard. So when you have people come in to see you and maybe they're planning on radiation, but you're thinking, well, maybe chemo might make more sense. Like what's I guess in a sense, to sort of help other oncologists maybe with their communication, do you have like almost a certain stepwise that you usually go through or asking specific questions? I know we talked about the pause. Any other kind of tips for people of trying to figure out the best way to communicate with someone, especially if maybe you're changing what they were originally thinking they were going to do?
Right. Well, I think they need to understand, or we need to understand, that we have to be honest, and not promise things that we can't deliver on. I try and be as optimistic as the situation allows and not be negative from the beginning. Being a negative oncologist doesn't help anybody. But I also want to have realistic goals. And I think asking people what their goals are, why are you here? And we have people that come in and they say, I just want to slow down the process, make him feel better. And we have people that want to bear no expense and want their dogs to benefit from everything that we can deliver on. And so it's really, I think, goal setting is very important, and having realistic goal setting.
And I like that you bring that up because I think it is extremely important to be both that balance of optimistic but yet realistic, right? So that they have a sense of what's going on. And with the goals, I will admit I've had trouble in the past trying to ask that question because sometimes if I outright say, what are your goals? It seems like it throws some people off. So do you have a certain way that you phrase that? Sometimes I'll say, what are your questions before I really start
Mhm.
going into things because that gives me a sense of what their goals are. But do you outright say what are your goals or how do you phrase it? Because I've struggled with this a little bit.
Right. I often do that. I start, I don't start with that, but I interject that during the conversation. as we kind of have a back and forth about that, when I give them, because sometimes people come in with a lot of knowledge, especially with the internet and whatnot. And I think that they'll come in and they may say, I'm here for stereotactic radiation therapy, not understanding that it may not be indicated in this particular case. And so, once we kind of have this back and forth conversation, I'll kind of take a step back and I literally will say, well, what are your goals for your pet? Most people can articulate it fairly well and you get a sense of it. And then you guide the conversation from there. And then if their goal is have the dog live a long time, but not spend a lot of money, then you navigate sometimes more to palliative care and not concentrate on, the more expensive options that may be appropriate, but not in the owner's pocketbook.
I think a big thing too is trying to figure out finances and, I think that's something that's a bit different between us and human medicine where it seems like with people they just kind of say, "Okay, this is what we're going to do," versus with us, we kind of have to give levels of, different things. So,
Right.
yeah, I think that makes a lot of sense. And just sort of thinking about, what people come in for, their goals and what they're wanting. How would you say just veterinary oncology in general has changed over the years?
Yeah, it gets changed tremendously. As you say, when I first started out and I told people I was a veterinary oncologist, they said I didn't even know dogs got cancer. And now when I tell people, most people have had a dog that had cancer, and many people have treated dogs for cancer. And I think that it is ever evolving specialty. I used to joke that the shortest book in the world was evidence-based veterinary oncology, but now it's no longer the case. We're not obviously at the point where we are in human medicine, but I think that we do have, as you say, a lot more data on biology of the disease, treatment of the disease. It used to be, we would say, it was surgery or radiation therapy or chemotherapy. Now, we have surgery and radiation and chemotherapy, and now we have immunotherapy. So that this multimodality therapy that really was not utilized historically is now being utilized. It's very commonplace.
And radiation, I think it's really changed a lot. You're talking about SRT or SBRT. I'm not really sure why sometimes we use the different acronyms or
Yeah.
SRS. Like, with I'm never really sure which one to use. But how has that technology changed how you treat or approach radiation with some of these different
Well,
cancers?
tremendously so, because historically radiation therapy, and as I look back now that we have very state of the art technology, I now refer to what we used to do as doing watch repair with a sledgehammer. A lot of collateral damage, a lot of normal organs that have potential to be damaged from radiation therapy. But now with the technology, it's much more precise, it's much more accurate. And the things that we previously couldn't treat with radiation therapy, now we can. We treat adrenal tumors, thyroid tumors, lung tumors, where previously we really couldn't do that at the doses that were effective. And so now we can treat, with curative intent, definitive intent therapy with low risk of negative impact.
Yeah, it really has changed a lot. And even as a medical oncologist, it's been good and also just trying to remember like, okay, what is a good candidate for radiation, versus in the past, maybe we wouldn't have used radiation so much for that. And something I'd be curious, just your thoughts on a couple different tumors with radiation. So, you hear a lot now about bladder tumors where we didn't used to really radiate, but now we're radiating and anal sac tumors. What do you think about those two? What's your recommendation or approach with those?
Yeah, those are very difficult tumors. I think that, the jury is out exactly how they're best managed. I think that, especially if you talk about bladder tumors, a lot of times we treat with surgery if we can, but based on location, surgery is often not an option. There have been some studies that do suggest that, radiation therapy prior to chemotherapy may lower the tumor burden. And certainly when we have, bladder tumors where there's obstruction, radiation therapy is very helpful to, de-obstruct them prior to do trying to do chemotherapy. Anal sac tumors, again, historically, when we did radiation therapy for anal sac tumors, most of these anal sac tumors cannot be removed with big margins. And often we would follow up with radiation therapy for incompletely or narrow excised anal sac tumors. But now the literature suggests that we may not need to radiate them because recurrence in the anal sac itself is relatively low. And so now we utilize radiation therapy for the anal sac tumors in situations where we have lymph node involvement or large tumors that can't be removed surgically. And they do tend to respond well to radiation therapy. So again, that's a situation, as I talked about, that the multimodality therapy definitely plays a large role.
Right. Yeah, those cancers can certainly be tricky for sure. So, and the other one that I heard more at the conference and kind of just buzz about recently has been like this half body radiation for lymphoma. I feel like it keeps going in and out of vogue, really. What do you guys, or what's the radiation community? I don't know if you can speak for that, but what are you guys' thoughts on half body radiation for lymphoma?
Yeah, I think half body radiation therapy may play a role. As you say, the literature is a little bit all over the map. Again, I think that, some of it is the technology will allow us to treat more effectively, more precisely. Even with half body radiation therapy, you still have to have concerns, of the kidneys and bone marrow. There are a lot of factors in how the half body is delivered. We used to use high dose rate radiation therapy. Now we have lower dose rate, and the current thinking is that the lower dose rate is more effective than the higher dose rate. It can be somewhat challenging depending upon the machine you have to deliver it at a low dose rate. And without getting into the physics behind it, but sometimes we can't do it. Like, for instance, our machine, it's very difficult to get the dose rate low, because we can't lower the gantry to allow the dose rate to be low enough to get to the low dose rate that some of the studies have been doing recently.
Oh, that's really interesting. I didn't realize the low dose and how just the physics with the machines that can be a challenge too. So that is really interesting. And you mentioned immunotherapy as well. What are some different immunotherapies or approaches that you guys are using?
Well, primarily we use immunotherapy for our melanomas, melanoma vaccine, and the ONCEP, and also the Vetmab, which are different strategies. I think immunotherapy has come to the forefront in the sense that, development of monoclonal bodies, development of strategies to stimulate the immune system. There's also a big interplay between, radiation therapy that can stimulate the immune system, and then adding, a lot of these immunotherapies once you, as they say, have a cold tumor that you can turn hot, that allows immunotherapy to work better. I think the challenge is, like anything, whether it's surgery or radiation or chemotherapy, with the exception of lymphoma, when you have big, bulky disease, many of these strategies are not as effective as when we have kind of more microscopic or minimal residual disease.
Yeah, it is interesting. And, I also heard some, like you were talking about big bulky or, trying to get down to minimal about maybe trying Gilvetmab before surgery. So the immune system recognizes it and then really following up after surgery because then you have less disease there. So I haven't done that, but it sounds certainly like an interesting concept with a lot of these. Have you guys done that approach or have you seen kind of things like that?
Yeah, we're early in the Vetmab experience, and so we've only treated a few patients, have not used it in a preoperative setting, more in a post-radiation or post-surgery setting.
Yeah. Yeah, no, it is it's an interesting I'll be interested to see, it seems like a lot of stuff coming down the pipeline. So hopefully we'll have some more things to use and kind of going along with that. What is some interesting technology that you're excited about or that you're seeing maybe even in human medicine that hopefully will get into animals? Is there anything on the horizon that you're excited about?
Well, talking about the radiation therapy is moving at lightning speed with the new technology. Currently when we do radiation therapy, we do radiation therapy using CT scan planning. We can often use MRIs to fuse the study. So a brain tumor that we don't see on a CT scan, where we see it on an MRI, we can fuse the information from the MRI to the CT scan and allows us to treat more effectively. They're now starting to have MRI-based planning systems. The other aspect of radiation therapy is what's called adaptive radiation therapy, where we can dynamically change the field, real time, and be able to adapt the dose that's being delivered based upon the size of the tumor or the position of the tumor within the patient. And that's especially important for tumors that have an initial response to radiation therapy, because a big tumor that gets smaller, the plan is based upon the big tumor. And so we have to change the plan pretty quickly or risk damage to the normal organ.
Do you think AI will be involved with trying to help planning? Because I know it can be really tricky and just the physics. It's sort of beyond me sometimes with radiation. So, do you see like is anyone looking at maybe AI to help you guys with some of these planning tools?
Yeah, we definitely, many people in the radiology community are concerned about AI taking their jobs away, because the AI can read the radiographs. In radiation oncology, we use it very commonly already with what we call auto contouring, where the AI can figure out what's the brain, what's the lung, and it can auto contour, so it can make our jobs easier and make it so that we don't have to spend hours doing the planning when the AI can do it. I do think that obviously it requires a real person to make sure that the AI is doing what it's supposed to do. But I think a lot of the first steps, which are often the laborious steps in terms of the planning, so it's already in place.
Oh, that's awesome. Because yeah, I just remember, radiation oncologists working on plans and it could just take forever, right? So that's where it would make sense to me that AI could come in and really help with that. So that's really cool. That is neat. Glad you guys are getting some good use with it. And certainly, yeah, I think it'll be interesting to see just healthcare in general, where AI is going to take us over the next, who knows, few years. Honestly, probably faster than we think in some ways. So my other question is just, kind of looking through your career and people that are up and coming, maybe veterinarians or newer veterinary oncologists, what advice or suggestions would you give them, even just from, academia, private practice? What would be some good tips for them?
I think that the most important thing is stay involved, keep current, give back. I think that serving on committees is very engaging. It's very helpful. It helps with networking. You meet people that you wouldn't have met otherwise. And you really, whether it's residency training committees or any committee, I think that those things are really helpful. I think that when you sign on to be a veterinarian, I think you're signing on for a lifelong endeavor. And it's easy to get complacent, and complacency is the enemy. And so, I say the same thing that I say to the students and the interns: read, read, read. And now, where that information is really at the tip of your fingers at the keyboards, there's really no excuse not to stay current. When we have cases that come in and it may be an unusual tumor, before I go in, I do a lit search and see if something has come up in the last month. And sometimes it is, and it may be something as simple as a retrospective study, but that information, it's a building block. And I think that that is key to doing that. Uh, so I think that those things are, critical to staying engaged and keeping it current and keeping you excited about what you're doing.
I think that is great advice and so true. I think if you just get complacent and don't really grow or challenge yourself, you get bored. And I think that's where some of the burnout comes from too. You got to keep growing. And I like the suggestions on committees. I should probably be better about helping out with some of the committees, but that's a good tip too, to just stay involved. You were the president of VCS, so you've certainly have been highly involved. And how was that experience?
A learning experience. I think that I never had a position like that, but you get to meet a lot of people. And I always say, yes, I work hard. It's not what you do 9 to 5, it's what you do from 5 to 9. And so I have a previous mentor of mine, and I used to say, I need more time. And, I need to find the time. And he goes, you don't need to find the time, you need to take the time. That is it's challenging, but I think that when you're seeing cases every day, that becomes the norm. And I think that the things that you do outside of your 9 to 5, I think that that's what gives you the real rewards. And I think that, going back to like practice, there are tremendous opportunities in consulting, tremendous opportunities to interact with academic institutions. And I think that previously veterinary oncologists were kind of not thought of as helpful. But I think especially in the pharmaceutical industry and the biotech world now, that dogs are, and to a lesser extent, cats are models for human disease. I think that the biotech world has embraced that. I think that when you meet people that know about it, they're very enthusiastic. When you meet people that don't know about it and you educate them, it's like a window is open to them to utilize the value of veterinary oncology.
Yeah, no, I totally agree, and I do think it is interesting how it's changed. Like you said before, we weren't maybe considered as valuable, but now, just with the technology and the dog as being such a good model for people, and I think that you're 100% that there's so much more we can do, and I really like that thinking about what you do from 5 to 9. What are you doing after hours and taking the time, not trying to find it. That's a good mind shift change and something for everybody to keep in mind because we all get the exact same amount of time, right? There's always 24 hours in a day. So I really like that. And this has just been such a great conversation. I love learning more about your experiences and just tips on so many things and just how kind and empathetic you are with your patients and just really enjoyed this. And before we wrap up, I always like to ask everybody who's someone that you would recommend for this podcast?
Mike Nolan, he's a radiation oncologist, PhD at NC State. He's a real successful researcher and, a great guy.
I totally agree. That's a fantastic guess. So I will definitely reach out to Dr. Nolan. So again, Dr. Ruslander, thank you so much for being on this podcast today. I know it's really going to help a lot of our audience.
My pleasure.
Well, that's it for this episode of the Veterinary Cancer Pioneers Podcast. If you enjoyed this episode and gained valuable insight, we would be so grateful if you could share our podcast with your friends and colleagues. And it would be even more wonderful if you want to give us a 5-star rating, positive review, or any kind of feedback on Apple Podcasts or wherever you listen. The Veterinary Cancer Pioneers Podcast is presented to you by Impromed.